thank you all very much for coming along today. And as Matt said, I lead the population health program here at Turning Point. And we have over a dozen projects that we're working on at any given time. And at the moment we have a staff of 22, which is about to go up to 25. And very busy group. And one of our rather substantial projects centres around ambulance attendances, and actually we have now 2 substantial projects that centre around ambulance attendances. And some of you may be aware of the alcohol and drug related ambulance attendance project that we've been running for a very long time here in Victoria, and we release data on an annual basis looking at alcohol and drug related harms in ambulance attendances. So excuse me, I have a rotten cough. But as Matt said, today I'll be talking about a project that has come out of that underlying alcohol and drug project here in Victoria, which is examining overdose and suicidal behaviour. And I'm really delighted to talk to you about it today. Any questions, please feel free to ask. For those of you who don't know, I'm legally blind. I have about 5% vision, so I will have trouble, particularly with these lights, to be able to see if anybody's got questions. So feel free to yell out, don't be shy, don't be polite, just feel free to interrupt or throw something at me if I don't know at the end that you've got your hand in the air. So by way of background, there's relatively little available data around drug-related harms, overdose and self-harm, particularly at a population level in Australia. And there's limited capacity to be able to monitor these kinds of harms across the population. Using ambulance service records, we have a really unparalleled opportunity to capture those harms and to be able to monitor them at a population level and in populations that we don't otherwise see in other data collection systems like general population surveys. So the background of this particular project, as I mentioned, it grew out of an underlying alcohol and drug project that we've been running in Victoria now for 15 years. And this project has been a collaboration with Ambulance Victoria and the Victorian Department of Health, and really examines in great detail ambulance attendances where alcohol or other substances have played a causal role in terms of overall inappropriate use of those substances. It was identified a couple of years ago that there was a real gap in terms of mental health related presentations, particularly self-harm and overdose, in terms of monitoring systems around Australia. And after discussions with ambulance services and with the Commonwealth Department of Health and Ageing, we received some funding from the Commonwealth to develop, implement and test the feasibility of expanding out that method that we use for alcohol and drug related ambulance attendances to capture overdose, self-harm and mental health, and to do that not only in Victoria but expand that to capture other jurisdictions as well. We initially proposed a 3-year project for that feasibility study. We were funded to do the whole feasibility study in 12 months. And we've just come out of that first 12 months of the study. So that was up until June this year. It was a very crazy year. And now we've been funded to continue that study and also to expand it. There were 3 jurisdictions that don't have the same clinical information system as Victoria. And so the first stage of the study covered the eastern seaboard, so 5 states. And now we're expanding that out to all jurisdictions to make a truly national project. There are issues around timely reporting of overdose and suicidal behaviour in the systems that are currently in place. So at a national level, the only system that's in place to be able to identify suicidal behaviour and overdose relates to fatal cases, and that's coronial data, which is very valuable and gives extremely detailed information due to the nature of the investigation, the toxicology results that come through, but there can be up to a 3-year time delay in finalisation of those cases. So when we're thinking about issues of clustering of behaviours or emerging drugs of concern, there's a real time lag issue that makes it very difficult to use that information to inform responsive policy and intervention. We also know that there are a whole range of harms that are not necessarily captured at all or are very poorly captured in other systems. So we know that suicidal behaviour, suicide attempts are poorly identified in emergency department and hospitals data, that patients are likely to recant or change their story the longer it is from when they've attempted suicide to when they're being seen by a clinician for a whole range of reasons: concern about being scheduled, concern about the implications for their family, for themselves, and regret about the actions that they've taken. So there can be some issues around recording that information. What's more, there are some types of suicidal behaviour that we can't easily extract from those kinds of data systems at all. So suicidal ideation, so if a patient is planning to commit suicide, they're expressing a plan, they have intention, they know what they're going to do, but they haven't yet acted, there's no way for us to be able to identify those cases separately in emergency department or hospital data. They get subsumed into mental health diagnoses, and there's no way to differentiate the suicidal patients from the patients who aren't suicidal. So we really have a lot of trouble getting to that information. And while we have general population surveys that give us information about suicidal behaviour and thoughts of self-harm at a general level, these surveys are conducted at most every 3 years. They're very expensive and very time consuming to conduct. The information is not available in a timely way due to the nature of data collection. And we know that people are likely to be reluctant to self-report many of these behaviours, both in clinical settings but also when they're being engaged in a survey. But furthermore, those general population surveys are most likely to miss the populations who are most likely to experience harm. So they're most likely to miss homeless or homeless populations or populations who have unstable housing, patients who, or participants and people in the population who have been or are in prison, for example, and people who are experiencing significant mental health or drug issues tend to be underrepresented in general surveys. There's a real need to have timely and robust information to inform evidence-based policy and intervention, but also to be able to evaluate policy and intervention. So without ongoing monitoring data, if we undertake an intervention or we change a policy, we can't actually determine if that's made any difference whatsoever, improved the situation, or actually caused unintended negative consequences for certain populations. And as Matt mentioned, this is a unique and innovative project. There's no project like this anywhere else in the country. There is no project like this anywhere else in the world. So it's such an exciting project to be able to work on and to be able to collaborate with so many fantastic groups. So I'll just very quickly say a little bit about how we do this project, and it's based on the methodology we use for our underlying alcohol and drug project. We receive data from ambulance services on a monthly basis, and that data is taken out of their data systems using an overly inclusive selection criteria. So we want to pick up all potential mental health, alcohol and drug, and self-harm related attendances. We then have a wonderful team of dedicated data coders who go through that information, go through every one of those records and identify any substances involved, any mental health aspects to the presentation, and any self-harm aspects to the presentation. In Victoria alone, we receive about 8,000 records a month. We discard about 25% of those after case review as not being relevant, but we'd rather receive too many and discard the ones that aren't relevant than miss out on cases that are potentially relevant to us. We need to undertake that additional work to identify these cases because there are issues of missing or unreliable information in the core approach that paramedics use to code the information. And that certainly isn't a critique of the paramedics. The way they use the system is entirely appropriate for how they're meant to use the system. It's for administrative and clinical purposes, and we're looking at monitoring and research purposes for using that data. So we take on that additional work to get the information we need. We know that we need to do that, particularly from our experience in the alcohol and drug space. We know that if we didn't do that additional work, we'd miss about 55% of cases where the patient's acutely alcohol intoxicated. We'd miss about 85% of cases where the patient has inappropriately used a pharmaceutical medication and required an ambulance as a result, so overdose and other presentations as well. So that extra coding is really essential to be able to get the detail that we need to understand these cases. And when we think about things like pharmaceutical related presentations, it's not appropriate to expect paramedics on the scene to be able to identify and classify every medication that a patient may have taken in an overdose. We get that information and then we're able to classify it. Across the first 5 states included, we get about 400,000 cases a year. So it's quite a substantial undertaking to be able to do this. It takes a lot of resources and a lot of hard work, to make sure that the coders are well supported in doing that work too. So just very quickly, what have we been doing in the first year? This is just one aspect of it. It's been quite a piece of work. So we received ethics approval for the project and had to negotiate with each of those first 5 jurisdictions to be able to undertake this project, and every state had different processes. So that commenced in October last year, and we went through those different processes, and it's wonderful to be working on this kind of project where there is such fundamental support for the project from every jurisdiction and from every government that we've spoken to. It's really wonderful to be able to do that. So we've had fantastic support from each of the services, and we've developed the project so that it minimises the imposition on each service. So we take on as much of the burden as we possibly can and support the ambulance services as much as possible to be able to do this. And we have a fantastic research fellow who works very closely with IT and other parts of ambulance services to be able to get the information and to do that in a way that is as supported as possible for the ambulance services and causes as little work for them as we can. So in the first 12 months we successfully engaged with Queensland, ACT, New South Wales, Victoria and Tasmania and their various legal departments and their various ethics committees and research coordinating committees. And in this second year of the study, we're now expanding out to develop a system for WA, Northern Territory and South Australia, and each of those jurisdictions use completely different clinical information systems for their data collection. So for each of those states, we need to build a system that works for them in terms of the data that they can give us. So we're going through that process of that negotiation now. The first 5 states that were included in the first 12 months of the project do represent over 80% of the Australian population though, so it's very good population coverage even in those first 5 states. And given that we have representation across the eastern seaboard, we have a good mix of different populations, of different geographic distributions as well. So what kind of information do we have in the data? We have geographic location, including the geospatial coordinates, so we can do some very fine-tuned mapping of hotspots, for example. The type of location, whether it's indoors, outdoors, whether the patient is found in a public location or private residence, which has a lot of relevance in terms of policy around alcohol and drug overdose, for example. The time of day, day of week, demographics of the patient, whether the patient was transported to hospital, and if they weren't, why they weren't. So we see a lot of accidental overdoses where the patient isn't transported because the patient is refusing transport. And it's important information for us to know in terms of how those patients are managed. Whether police co-attended the case. A whole range of clinical information that we can then use, GCS, the treatment that's provided by paramedics, pre-existing medical conditions and medications, and we have the alcohol and drug markers that we use in our underlying AMBO project. So this just gives you an example of how we can geocode. These are heroin-related attendances in North Richmond. There was a request from the Department of Health to have some better information around the geographic location of these attendances, to see what's happening over time and whether there are any particular hotspots where people could be better supported to reduce the chance of overdose. So what are we collecting in terms of suicidal behaviour and overdose? We've taken the opportunity to be as thorough as we possibly can and collect as much information as we can to really support policy and intervention opportunities. So we're coding for suicides, including the modalities. And it's important to note that we know that we will underreport suicide, that completed fatal cases, not all are attended by ambulance, and in some cases we don't have enough information from the paramedic report to be able to determine it as a suicide. That needs to be investigated by coroners, but there is capacity potentially to work with coroners to be able to link in and actually get a more complete picture. There are also cases that would be suicide that when they're in our data they're actually an attempted suicide and they become a fatal case once that patient reaches hospital. We also capture suicide attempts, the intent of the patient, so whether there's evidence that the patient had attempted suicide and where the patient is denying that. We have quite a few cases where that happens, so we're capturing that in terms of how these patients present and how their presentation changes over the course of their attendance, and the modalities. In addition to suicide attempt, we're also capturing suicidal ideation where the patient hasn't yet acted on those suicidal thoughts. The intent of the patient, whether they're vocalising a plan, and if they're vocalising a plan and they're talking about a modality, we also capture that. And that really speaks to quite a substantial evidence around the likelihood of a person later attempting suicide if they are suicidal, but they're also expressing a plan. They have a plan in place of how they're going to commit suicide. We also capture self-injury cases where the patient isn't actually attempting to commit suicide, including the modalities self-injury threat, which can be very time-consuming for paramedics and for police. And in terms of overdose, not only do we capture intentional overdoses as suicides or suicide attempts, we also separately code for accidental overdoses and overdoses where we can't determine the intent from the information that's available. So in terms of accidental overdoses, the most common ones we see are for heroin, for GHB, for other CNS depressants, And we see quite a few overdoses that are alcohol-related overdoses. And when we're talking about accidental overdoses, we use quite a narrow definition as well. So we look at the patient's level of consciousness, whether they're able to protect their own airway, whether they need to be intubated by the paramedics, concern about the patient actually staying alive long enough to get to hospital. And because we have the information about alcohol and drug, we can also look at the substances that are involved in these overdoses as well. In addition to that, we're also capturing current mental health symptoms. We can't capture a current diagnosis. Paramedics don't diagnose, and nor should they on the scene. But certainly where a patient is presenting, say, with symptoms of psychosis, then we're capturing that information. When a patient is anxious, expressing or displaying symptoms of anxiety, we're capturing that information as well. Past mental health history, which is very commonly provided by paramedics. Predictors and also service engagement. We capture information about whether CAT teams are involved, whether the patient is linked in with psych and other health services, what level of social support they have. And we also capture information about life stresses, and it's remarkable how common this information is reported by paramedics. So the patient had attempted suicide, it was the anniversary of their partner's death. Bereavement, we will capture that. And we do that for a whole range of different life stresses as well, including job loss, homelessness, post-prison release, whether the patient's in custody, whether they have a past history as an asylum seeker or a refugee, family issues including domestic violence. So we have quite a range of different life stresses that can contribute to the presentations that we see. In terms of the drugs that we capture in this project, it's substantial. On the left-hand side you can see all of the illicits that we capture, but importantly we also capture illicit substances, so alcohol, whether alcohol's involved, and additionally whether the patient is acutely alcohol intoxicated. We also code for a whole range of pharmaceutical drugs, and not just the drug group, we actually code for specific preparations in each of those drugs, so we can really drill down onto what drugs are involved in overdose, what drugs are involved in drug-related presentations, and that is not available in any other system either. It's not possible to do that with hospital data, for example, in terms of diagnosis. So just to give you an example of how we do that, this is some recent work that was led by Cherie Heilbronn in our team, looking at atypical antipsychotics, and this followed on from concern around Seroquel or quetiapine-related harms, both anecdotally through a number of projects that we're doing, but specifically through our ambulance attendance data. And these are rates of attendance per 100,000 population, and comparing 3 different atypical antipsychotics. So we have quetiapine, which is Seroquel, risperidone and olanzapine, and what you can see there is the substantial increase over time in quetiapine-related harms compared with other drugs in the same drug group. Can't do that with other data systems that we have in Australia. Importantly, in the work that we've done in this area, we can also look at what predictors might be contributing to these attendances, and also the characteristics of the patient and how they might be similar or they might differ from other atypical antipsychotic presentations or even from other drug type presentations as well. So in terms of the data that's come from this project, now this is data for the first financial year that's available, so July 2012 to June 2013, and as Matt mentioned, it's very timely data that we have available to us. So we receive data within about 4 weeks of the end of a month from ambulance services. It varies by service, and our fantastic team of coders code very quickly. In fact, we're coding some New South Wales data at the moment. I was coding as well before I came down here today. And we turn it around as quickly as possible. So we're reporting to the Commonwealth within 3 months of the end of a month of interest. So by the end of September, the Commonwealth will have data for June 2013 from all of the jurisdictions. In the Victorian project that we do for Department of Health around alcohol and drug-related attendances, we report within 2 months because we have that ongoing relationship with Ambulance Victoria and we get the data in a very timely manner. As you can see here, the numbers of overdoses, and these are just accidental or overdoses where we can't determine the intent, were substantial in the financial year. We had nearly 2,000 attendances that were accidental overdoses, nearly 3,000 that were with unknown intent. Accidental overdoses occur predominantly in metropolitan areas. They're driven by men. The age is fairly similar across these 2 areas, but importantly there are some differences in these attendances as well. And what we see as we go through is the overdoses where we can't determine the intent mirror more closely suicide attempt overdoses that we see as well. And getting this level of detail of information, we can actually look at specific subpopulations and the kinds of harms that we see and be able to segment and look at issues for those specific subpopulations. So just to give you a bit of an indication of the distribution of accidental overdoses, these are rates per 100,000 population across Victoria, and the insert is metropolitan Melbourne. And you can see here that it really does differ from the overdoses with unknown intent. that we see higher levels in regional areas than we do for accidental overdoses. The next two slides give you a bit of an indication of the drugs that are involved in overdose across now the three areas. So accidental overdose, overdose where we can't determine the intent, and suicide attempts. The completed suicides with drugs on board we haven't included here because the numbers are fairly low. And what we can see here is alcohol plays a substantial role in the overdoses that we see. So even with the suicide attempts, it's over 20% of attendances, the patient is acutely alcohol intoxicated, and around a third of patients have some level of alcohol on board. Very different kinds of presentation in terms of the other drugs. But when we get to the pharmaceuticals, we see some interesting information here. I think it's really important to note in the final column, we see a lot of benzos in suicide attempts, as we'd expect. But really importantly as well, non-opioid analgesics are what we see, the second most common in suicide attempts, and this is really driven by paracetamol. And we often don't see the patients until 48 hours or so after the overdose when they're starting to become symptomatic, when they're going into liver failure, and the patients aren't aware that that's the trajectory of their overdose and what they're in for. So we see really substantial harms in relation to over-the-counter non-opioid analgesics. And we can actually look in the data at combination drugs as well as individual drugs, so we can look at codeine combinations, we can look at opioid analgesics together with non-opioids, and I was coding one today that was an aspirin and paracetamol overdose combined, and so we can actually really unpick those and look at specific population groups at risk. In terms of the suicidal behaviour cases, we had just under 150 cases of completed suicide that we could determine as completed suicide based on the data that we had available to us, and as I said, we know that's an underestimate. But what's important to note there is the proportion that are metropolitan attendances. Now we have a population split in Victoria of about 75% of the population is in metropolitan Melbourne, about 25% in regional Victoria. And what we can see here is that metropolitan Melbourne attendances are actually underrepresented based on population size. So we're more likely to see completed suicides in regional areas. But when we look at the other types of suicidal behaviour, they're fairly equally distributed across metropolitan and non-metropolitan areas. Men represent the majority of completed suicides, whereas women represent the majority of suicide attempts. And this will relate in part to modality. We see alcohol involved in a substantial proportion of these attendances. Police are involved in a substantial proportion as well. What's really striking in this data are the sheer numbers of suicide attempts that paramedics actually attend. So we're talking about 6,500 in a 12-month period just for Victoria. And when we commenced this project, nobody anticipated that the numbers would be that high. Not paramedics, not the Commonwealth, not us as researchers. And it's really quite striking the degree of burden that we're seeing in emergency services and the degree of burden that we're seeing in the community around suicidal behaviour. You'll note that there were nearly 7,000 cases of suicidal ideation. This is in addition to suicide attempt. So this does not include the patients who have attempted.
So Belinda, can you just unpack a bit what sorts of situations would be involved in that suicidal ideation? Like I know there's probably a lot of different situations, but just, some themes.
Certainly. I mean, so we do see a lot of cases where the paramedics are called specifically because the patient is expressing a desire to kill themselves. And so the paramedics are either called by the patient, by a family member, by Lifeline, by a CAT team, and there will be a whole range of mental health issues going on, but the patient is explicitly expressing an intention to commit suicide. They may be preparing to commit suicide and they're stopped. So quite a range of different things, but routinely that's the primary reason for the call out. Does that clarify for you? Yep, sure. But I mean, there is quite a degree of variation across the kinds of presentations we see.
And attempt, like that's, there's a few shades between that, so that kind of different.
Absolutely. And we do, part of this process, in addition to working with all of the jurisdictions, was actually working out how we would define these and how we would work through it and then be able to train the staff to be able to do that coding so we have consistency and work through that. So we actually have a manual for staff to be able to make sure that we're consistent. And we err on the side of caution. Where there's some uncertainty, we will go for a more conservative coding option rather than inflating the numbers with cases that are potentially aren't relevant. For a suicide attempt, the patient needs to have acted or attempted to act. So if they have been stopped by someone but they have actually engaged in an act, that would be considered a suicide attempt. If they've prepared to act but they haven't yet acted, that would be suicidal ideation. So a suicide attempt, if someone has gone to the railway station and lain down on the tracks, we would treat that as an attempt because they've actually acted, even if the train hasn't yet hit them. But if they're talking about, I'm going to go out and get hit by a train, then that would be a suicidal ideation. But as you can all imagine, there's an awful lot of grey. This is not a standard coding job for anyone, and we really actively encourage the staff to actually talk about the cases as much as possible, to get second opinions, to discuss them. We do a lot of review of those cases, and we really work as a team to be able to address those issues, so we have consistency. But it doesn't matter how many examples we give, every day there'll be a new case that nobody had ever thought of seeing something like the presentation that we see. So it's it's always something new. And of course, when patients are presenting with multiple modalities, we can pick that up as well. And we do say that. I think we had a case yesterday where the patient had attempted with 6 different modalities. So every time they were stopped by someone, they ran off and tried another one. Hadn't yet succeeded, but they were very intent on doing it. And so we can code those multiple modalities and really unpick what's happening there. But the sheer numbers of these cases represents a really significant public health issue in how we actually address this and how we most appropriately treat patients and also refer them through systems. And these kinds of cases are very difficult for paramedics to manage and very difficult for police to manage. And often, the outcomes aren't ideal in terms of how patients can actually transition through different systems and through different points of care. We're really keen in the future to link this data in with mental health data as well and look at how patients actually engage with different systems. But that's an opportunity for the future because we don't have enough to do at the moment. And you can see there are quite substantial numbers of self-injury and self-injury threat as well. It's just in terms of the population distribution. Again, we see quite a lot of variation across different areas, and because these are rates, they would control for that fact that we'll have different population sizes in different areas.
Can you?
Yes.
The red.
Oh, don't ask me a colour question. I'm colourblind.
Sorry.
No,
Okay.
quite all right.
No. The mallee, it looks to me like mallie's near the top of the thing, isn't it?
Yeah, absolutely. In terms of suicide attempts, that's per 100,000 population, yeah. So being able to really drill down on that local area, and we can actually do this kind of mapping as well at a postcode level, to really see the areas where we've got really high risk and there may be need for additional services and additional support. So suicidal ideation is a different picture again, and so being able to really break that down into different population groups in different locations is an important thing to do. Self-injury, we see something different again. So we're talking about really different kinds of presentations and different populations presenting as well. So different underlying issues. There's a lot of information on this slide. This is all going to be available online, by the way. So, there's a lot there. And as an epidemiologist, I love data. I can't get enough of it. But what we do need to think about, and there certainly is existing literature around this, is the different kinds of modalities people use for different kinds of acts. And in terms of completed suicides, they're really driven by hangings, and that's a reflection of the high level of success of hanging in terms of a fatal outcome. There's not a lot of time for intervention, and things can go wrong and people don't complete, but we see a lot of completions. Still substantial numbers of overdoses, and often it's harder for us to identify a fatal overdose as a suicide because of that level of information at the scene, and sometimes time can be a factor as well if the patient's not found for a number of days. Vehicular impact we see as well. Inhalation is an issue too. But when we look at suicide attempts, the vast majority are overdoses. Our AOD overdose is the modality that the patient has used. We see much less of the others. And again, that then raises issues of it's much less likely to be a modality where it's a completed event because there is more time for someone to intervene, but also there's more chance of something going wrong. So if the patient then vomits, that they may not complete that event. And often we see in those cases that they're really repeat presenters trying different modalities or multiple overdoses, not completing, going back and trying again. And I was just coding a young patient today, he was in his teens, who had taken a paracetamol and aspirin overdose, initially denied that it was a self-harm attempt, then admitted that it was, and then started discussing with the paramedics, well, if that's not going to be a fatal overdose, how many do I need to take to make it fatal? In terms of suicidal ideation, we see a bit more of a mix as well. So people talk more when they do disclose what their plan is around vehicular impact, being hit by a car, crashing their car, being hit by a train. Do also talk about firearms to some extent. We've had a few cases where the suicide is a suicide by police, so that the patient has been attempting to kill themselves by getting the police to shoot them. So we see a real range. We constantly see new things in this data. But again, the numbers are substantial and much more than we'd anticipated. Just in terms of the distribution over time of day, and this is the time of the ambulance attendance, I just want to be really clear. So in terms of suicides, they really peak in the morning. And they really peak in the morning because that is when someone doesn't show up to work, family members are checking on someone, and they discover that the person is deceased, or police have been sent around to do a welfare check. In terms of other self-harm and overdose, we do see them peak in the evening, but around 8 o'clock at night is when we see the peak. And this kind of information, when we can model it over time, is really useful in terms of resource planning and looking at those referral pathways and what services need to be available when to be able to most effectively support emergency services, but also the patients as well. In terms of the day of the week, we see a bit of a peak on Wednesdays. Yes. It used to be when we were just coding for drug and alcohol, the coders would be reluctant or anxious slightly perhaps about the Friday night, Saturday night and Sunday, because we get a lot of the Saturday nights rolling over into Sunday. Now Wednesdays are often our peak day for cases. And just in terms of the distribution over the course of the year, it's fairly stable. We do see peaks in self-harm behaviour around the Christmas New Year period, which we know is a common feature, but not as much of a peak as we necessarily anticipated. And just quickly, in terms of mental health symptoms in presentation, you can see that anxiety represents a really substantial burden on the community and also on emergency services. We had nearly 17,000 anxiety-related presentations in Victoria in that financial year. That's really substantial, and often they present, or the call is a chest pain call, and so it's a priority 1 call, and the patient is experiencing anxiety and is treated in the home with breathing techniques and a whole range of exercises, and don't require transport to hospital. But they can be very time consuming again. We still see substantial numbers of presentations with symptoms of depression. Not every case that's a suicide attempt or suicidal ideation is going to be coded as the patient expressing symptoms of depression, because often they don't. It's not a foregone conclusion that if we see one, we'll code the other. It has to be explicitly stated. There has to be clear evidence of it in the case. Again, we're conservative in our coding so that the data is robust. If we underestimate, we underestimate. We'd rather do that than inflate the numbers. But again, we see a substantial impact, and because we're coding the alcohol and drug data, we can actually look at cases where a patient may be presenting with symptoms of psychosis and the drugs that they have on board at the time. And just in terms of the pattern we see for mental health diagnoses, it's remarkably common, or mental health symptoms, again coding into the afternoon and evening, and pretty stable across the course of the week. Again, we have that little peak on Wednesday, but that's about it. So there are a whole range of opportunities that come out of this. This data really provides us with a fantastic basis for ongoing monitoring and surveillance, and to be able to then support policy by giving information that's timely, but also has a high degree of utility. But there are other things that we can do with it as well. So we can examine the issue of clustering, and this is of particular relevance around suicidal behaviour. It's certainly an issue that's commonly raised by policymakers and by clinicians, and different kinds of clustering as well, because we have the level of detail we have. We can look at geographic clustering down to a geospatial coordinate, so a specific location when we're thinking about level rail crossings, for example, which are often a particular concern. But we can also look at specific population groups. We can look at temporal clustering. So when you see a series of self-harm attempts following on an initial self-harm attempt, and we certainly do see that even in the data as it's being coded. So we had a day relatively recently where there were a series of suicide attempts, and there were a series of suicide attempts by siblings in the same family, all within the space of a couple of hours of each other. Adolescent siblings of a family, one of them was successful and the others were not. And we can also look at behavioural clustering as well. So when we see a high profile case, for example, in the media, and we see a series of events that follow that may be engaged in the same behaviour. So a whole range of different ways we can look at clustering. There's scope to undertake data linkage. We've actually already done that with the alcohol and drug data in Victoria, linking with emergency department presentations and hospitalisations. And that gives us an opportunity to look at clinical issues and how patients actually transition through different care settings and where there are ideal opportunities for referral and intervention. Gives us an opportunity to look at the true burden of these kinds of cases on different healthcare systems. And because we have the level of detail in defining these cases that we do in our data, where we do have limitations in, say, emergency department data or hospitalisations data, we can actually use the information we can gather from the paramedic records to be able to give us a better way to estimate the true burden in those different settings. And as I mentioned before, there's real scope to potentially link this data in with other services as well. So we'd really love to link in with specialist alcohol and drug treatment services, with outpatient mental health services, simply to better understand how patients engage with different aspects of the system and where their needs are being met and where they're really struggling and where there are opportunities to improve referral to different services and support patients so that they're not bouncing in and out of these services. Many of the patients we see in ambulance are very frequent presenters to ambulance, multiple times a week often, are well known to paramedics, and even when they're not necessarily well known to the paramedics, they're often well known to the ED when they're actually transported through to the ED. A frequent presenter, we see them several times a week with this kind of presentation. So to be able to better identify and better be able to respond to those kinds of cases is really important in terms of the efficiencies of the system, but also in terms of clinical outcomes. There's also scope to look at outcome monitoring, so we can actually look at patient pathways over time and how treatment effectiveness actually improves engagement in social life and reduces harm for different population groups. We can undertake time series analysis. We've done this with alcohol in particular recently, where we can actually look at longer periods of time because we have such detailed information. We can adjust for effects, seasonal effects, time of day effects, day of week effects, and to be able to look at patterns over a longer term period. Very useful for resource planning, but also in terms of how we might target specific interventions or prevention campaigns. We can look at correlates of harm, and as I mentioned, we're coding for a whole range of different factors that may contribute to presentation. We can look at enhanced planning and referral approaches to be able to transition patients into different systems that may be more useful for addressing their needs than emergency services. We also use it for development and evaluation of policy and intervention, and this is really important. And as we work with ambulance services, there are so many different questions that are raised by different services that are priorities for them in terms of workforce planning, workforce development, looking at different referral pathways so that they can feel that they're doing a good job by their patients and get better outcomes for their patients as well. I'd just like to take the opportunity to acknowledge an awful lot of people. This project was funded by the Commonwealth Department of Health and Ageing. We have a fabulous project team working on this. It's just wonderful to be able to work with such a great bunch of people. We also had a working group to develop the case classification and the systems that we're using, the definitions that we're using, and that included medical staff, psychiatrists, ambulance paramedics and ambulance research staff, epidemiologists, and social scientists. And so to be able to get those different perspectives to see how we identify these cases, how we code them, and how we do that in an appropriate way. We have a reference group across the country that was convened by the Commonwealth and has representation across health and law enforcement and service delivery. We've worked very closely with Ambulance Victoria to develop this, and also need to really acknowledge the other jurisdictions that we're working with and have really embraced this. And we have 58,000 different logos there. I'd particularly like to thank Caroline, who's up the back, who ran all of the data, the coders, who did all of the coding, and also for the beautiful photographs that were in the beginning of the presentation. They were from Ambulance Victoria, so I just have to mention that as well. And those are contact details, and now I'm going to stop talking and you can ask questions. Thank you.